So these are the levels we're looking at. Mild, moderate, and severe. And I think I mentioned this before. Once you hit 70 and above, you're really looking at severe levels of, so you're putting the child at risk for brain damage, seizure, brain anoxia. Levels of 10 to 44, they might start with just some oral agents to give them. We'll talk about those in a minute, like Succomer is a very popular one. It's a PO pill. What you want to watch is they do work out of the renal system for excretion. So they increase the excretion in the renal system. So if you're going to give something like that, you want to make sure the kidneys work and that you don't have issues with BUN and creatinine prior to giving it. And then at 45 to 69 levels, they're going to actually hospitalize that child and have them go through dialysis even. So again, you want to remove the lead from the whole environment, and then obviously from the child's blood themselves. They can do chelation therapy. When we look at diet, we want to increase the iron, obviously, right? Because we said that iron is what's lacking, or the effectiveness of the iron. And we want to decrease fats, and that goes back to the fact that lead is very attracted to fat. So if you have increased fat in the diet too, you're more likely to retain the lead. Chelation therapy with something like Succomer, which again is a 19-day PO medication. What you want to keep in mind, and again, two things you want to keep in mind. This does cross with some penicillin allergies. The other thing too is you want to check BUN and creatinine for any of these meds, because they do work, most of them do work through urinary excretion. Although the BAL and the peanut oil, we gave this actually, the British Antillice and peanut oil, we were giving a girl that every 6 hours. The one that I was talking about that was at North Fisher, we were giving her that every 6 hours. And it's IM injection, extremely painful because the peanut oil makes it very thick. But that's what keeps it active ingredients, that it works when it's in the muscle. And that is urine and bile. So actually stool, it's released through the GI and the urine, the kidney system. She was getting IM every 6 hours, but her level was not quite as high as 70. And sometimes they will even do dialysis to try to get out even quicker if they feel it's if it's very unstable and they're very high. So again, we want to educate the public on hand washing, playing outdoors, removing shoes if they're going through areas, or if they work in areas with high lead, showering and changing clothes, again, if they're working in areas with lead. If the lead is present in paint, use a state-certified abatement contractor. Sometimes you will get parents or families that will try to do it themselves, and then they end up sick, nauseous, vomiting, headaches in the hospital themselves, because they don't have the money and they want to get rid of it in the environment themselves. Plus, you don't truly know if it's gone. So these guys make a lot of money, but again, it's a service that kind of guarantees that it is gone in the area. Nursing care, you really want to watch to prevent against, you want to watch and monitor for encephalopathies, seizures, central nervous system issues and irritability. Increasing fluids is highly recommended because again, they're going to be excreting quite frequently now, especially through the kidneys with this. Monitor BUN and creatinine levels and increasing the iron and protein and reducing fat in the diet. The other big thing with hematology that we're going to talk about besides lead poisoning is sickle cell disease, sickle cell anemia, which goes along with sickle cell crisis. So what do you guys, have you seen any of that? Or I think those of you that went to North Israel, they used to have a hemo clinic there, right? Hematology oncology. So there used to be a lot of sickle cell patients that would come in because the doctors were there. They had a clinic that would monitor them. Does that sound familiar still, or?
There's a lot. There were like 5 on the floor on Sunday.
Yeah, and that's usually why, because they do have a, like I said, they have a clinic there. So the doctors follow the patients. Okay, so some of you might have taken care of patients with sickle cell then. So what is it? Go ahead, Steph.
On my unit at work, we do blood exchange.
Okay.
So we have a lot of sickle cell patients that come in for whole blood exchange or red blood cell exchange.
What's wrong with their blood?
The cells are shaped improperly, so it's harder for them to get through the vessels, and it causes a lot of pain.
That's right.
So they're almost always in pain.
Yes.
Lots of pain meds, pain all the time. And when they get the blood exchange, then they usually feel better pretty much right away.
Mm-hmm.
But it's lifelong.
That's right.
A lot of our patients are very young, we don't do pediatrics, but a lot of our patients are we have a 19-year-old in their 20s, and then they have to come every 2 weeks to
cells or those abnormal red blood cells don't carry oxygen as well either. That's why it's called the anemia too. And under stress, the body makes more of them, so they can go into crisis, which actually means that the red blood cells break down quicker, which can cause splenomegaly, because red blood cells go to the spleen when they die, right? So it can actually cause like a splenomegaly. Many of them have their spleens removed, rather than having them stay there, because if it ruptures and they have internal bleeding, they could die. So they actually do splenectomies on some of these patients as a preventative thing, so that they don't, or because they might have had bleeding and they wanna prevent that. You're right, the very small vessels, joints especially, can be an area of problem for pain. There can be, very small vessels are where these sickled red blood cells get caught. They actually get caught there, they coagulate there, because they can't move through these small vessels. So things like the eyes, the retina of the eyes, they can have blindness. The brain, there can be a stroke. I've had patients who are rehabilitating after a stroke. Kidneys, exactly, they can go into kidney failure and have kidney issues because the kidneys with the very small. So all of these areas can be, the fingertips, extreme pain, in those areas too, because of that. So things like the blood transfusions are one of the things that can help with that. When they're actually in a crisis and they have the severe pain, they're at risk for, as I mentioned, strokes, heart attacks, kidney failure, acute kidney failure. So then you really want to make sure the pain medications are very high. Things like morphine work very well, because morphine, as we mentioned, even with tetralogy of Fallot, it's a vasodilator. And the last thing you want is vasoconstriction in people that have a tendency to coagulate or to be able to have sluggish blood because of these sickled red blood cells. So the morphine helps to relax them, helps to decrease their pain, because when you're anxious, what happens then? If I'm in pain and I'm anxious, what's my body going to do? Vasoconstrict, because I'm going to release epinephrine and norepinephrine, which are my stress hormones, right? And my stress hormones are going to make me vasoconstrict, make my heart beat faster through these narrower areas with this sluggish blood. Then what's going to happen, right? So what I want to do is give something like oxygen, morphine, IV fluids, that's right. All those pain relief measures. No ice, but I want to put ice on a joint if it's bothering them. No, because what does ice do? Vasodilate, and vasoconstricts again. I want to dilate, so I want to give things like heat. Exactly. So these are the kind of things you want to keep in mind when you think about when you think about treating the patient. So I'm treating a patient who's in sickle cell crisis. What would I do first? IV fluid. Somebody's saying. Somebody else is saying oxygenation. Somebody's saying morphine. All right, raise your hands if you think the first thing you'd want to do is oxygen. Okay, Ina, good. She's just oxygen. Okay, so let's think about that for a minute. Oxygenation. What's wrong here, though, pathologically? What's going on?
Blood
The
is
cells
sluggish.
already shaped not right, so they're not gonna bind with oxygen when they.
That's right. Goddess said you have cells that are not naturally shaped to carry that oxygen. So while you will need oxygen, it might not be the first thing I do because I'm not going to have the cells grabbing it as easily. I'm going to do it. And again, when you're in the hospital, you're probably doing everything kind of at the same time anyway. But if I had a test question, it wouldn't be my first choice. What about IV fluids? Yeah, you said IV fluids. Melissa.
Yeah, probably fluids, because you wanna, if they're hypercoagulating, you wanna put more fluid into them.
I'm going to put more fluid into them, but they're nervous and they're anxious and they're in pain, so they're vasoconstricted.
Pain medications,
The answer is pain.
When you think about sickle cell,
Rip out the IV, because they won't.
yeah, and the pain meds do make them feel much better, Stephanie. She was saying that patients get very agitated and anxious and they're in extreme pain, so the pain meds actually calm them and make them better, and they open up everything, so that now I'm able to take in the oxygen and the IV fluids and help to move things along. So yes, the morphine, the pain meds, morphine is like the gold standard, but obviously there's others too. There's others too, but morphine works very well.
And they know,
Yes,
like, it's not
Yes.
an acute disease, so like, by the time they're older,
yes,
they know exactly what's wrong, and like, they know that the pain med is the only thing that's gonna make them feel
that's
better
absolutely
right
right.
away.
I had a patient in North Bath years ago who was, I want to say 19, 18, he was a freshman in college, and he came, he was having exam time, this time of year, all stressed, and he came in, and he said to us, we had a student taking care of him, and he was not talking much, very polite, but not talking much, and he said, they're not giving me the right dose. He was on a PCA, plus he was getting some breakthrough morphine, which is common, and, on top of the PCA, and he said, this is not the right dose for me. I'm supposed to be on such and such a dose and such a frequency, and like he knew the exact programming of what he needed while he was in the hospital in a crisis. And doctors and healthcare practitioners don't like to be told what to do. So they were kind of like, let's try this first, you know. And he was very quiet, and the student's like, I don't know if he has pain, you know, he's not really saying, and he was like, no, 10. And I'm like, yeah, but this is somebody who deals with pain chronically, so that doesn't mean he doesn't have pain because he's sitting there calm and telling you 10. Well, the next day we went into his room, and his doctor had come to visit him.
Adjusted to the pain.
They adjusted to the level that he had mentioned, and he was sitting there smiling, laughing, with his books out, studying, like a different person. And the student's like, he's a different person. Hmm?
And he's verbatim for exams, that's why.
But he spoke, he was happy, he was laughing, they were like, he barely talked to me yesterday. And the student just thought he was adolescent, didn't want to be bothered, wanted to be left alone and sleep. But no, he was in pain, and he was like, you know, and he was telling people and they weren't listening to him, and he was being polite, but he was like, I'm in pain, it's not helping. And he was just not, and the next day he was like friendly, outgoing, you know, like a different person, like he had, you know, probably his normal self. So, you know, again, it is something that's really needed, and unfortunately, it is one of the diagnoses that gets the reputation of drug seeking, or that people a lot of times don't give them the proper meds that people need who have this diagnosis. So again, there's all various types. It is autosomal recessive, which means that both people are carriers, and that in order for them to relay it. Now, there is a certain type of sickle cell that is a carrier type, where people have mild versions with extreme stress of the sickle cell crisis themselves, and they are just the carriers. But for the most part, to have this full-blown sickle cell disease of what you're talking about with the blood transfusions and having the crisis and everything, it's autosomal recessive. But my point is, there are some carriers with, under extreme stress, will start to get the pain, will start to have some of these symptoms even, when they're sick. And it doesn't appear in infants until about 4 to 6 months of age. Why is that? Why doesn't it show in infants right away if they're stressed? That's right. Does everybody hear what Ina's saying? They have the maternal fetal hemoglobin, which protects them, actually, from this demonstrating. So here's just an example of the different organs that can be affected from it, especially the spleen, as we mentioned, to abdominal pain even. And here's just another picture that kind of shows how, again, there's an issue of these red blood cells and how it can cause this vaso-occlusive crisis. And the spleen too, because it's so overactive in collecting all of these red blood cells. Clinical manifestations, pain, obviously. The person has had an increased risk of infection if they don't already have one. Sometimes things like dehydration, infection, stress is what puts people into these issues. There could be hepatic blood flow issues, kidney perfusion issues. So again, these bring us back to all these things that you can see, which we talked about. And usually the first crisis develops after 4 to 6 months of age, as we mentioned. It can be with them getting sick. The fetal hemoglobin eventually decreases, and then the regular hemoglobin takes over. So while they do run tests when the infant is younger, like newborn even, they will say that they want to recheck sickle cell in 4 to 6 months of age, because it's not really definitive until they're older than 6 months of age for sickle cell. So again, mandatory infant screenings. And there is no cure. As Stephanie mentioned, it's lifelong chronic management that needs to take place. So avoiding strenuous sports, avoid environments with low oxygen. Obviously a place like Denver wouldn't be the best place for them to live. Especially if they came there, from an area like this and then moved to somewhere that's high altitude with less circulating oxygen. Non-pressurized planes. People say, well, all the planes are pressurized now. Small private jets, small planes are not. So if they're really going something like that. Immunizations, hand washing, even something like a lot of mountainous areas, which we could be around even too, would be something to be avoided. And preventing dehydration. One of my patients actually had gone to a class trip. She was 16. She went on a class trip to Great Adventure. It was like in the May kind of time frame, or April. We were there doing clinicals, and she had gone out to Great Adventure, was going on all the rides and running around excited, having a good time. It was a warm day, not really drinking as much. And then she was in the hospital a day or two later because she was having a crisis. So again, you don't want to force fluids, but you want to make sure they continue to take fluids. And don't hold the fluids if they're starting to go into kidney failure, having enuresis, because that will be resolved. Usually it's resolved fairly quickly. So again, sometimes people will say, oh, if they're starting to go into kidney failure, any other patient, you would hold fluids, but not necessarily more strict. And then during a crisis, Okay, we have everything listed here, but not necessarily in the order you would wanna do it, which we did talk about. So pain would really be the first thing, and morphine is usually a drug of choice. Reducing the oxygen consumption and fluid management would be the next things. Okay, and